Hello, hello. How are we all doing today? Great, great. I've been reading comments in the course. It looks like everybody's getting good results. Love it. Awesome. I'll wait a couple minutes to see, just as people get in. If you have any questions that you're hoping that I answer tonight, you can go ahead and drop them in the chat. I wrote down some notes from some of the questions that were in the Teachable. And then the lecture I have planned for today will cover a bunch as well. But don't be shy about asking questions. This is your opportunity to get all the answers from me. I know it's a lot of information, so it's a lot to filter through. Let's see. I'll drop the notes in the chat. The notes I also emailed you. The last email that went out like 15 minutes ago. For those of you on the call right now, I'll share in the chat. Don, that's a great question about the Corgus ball visceral treatment. So I will make sure I talk about that when we get to that section of the presentation. For sure. Another question, doesn't mean if anything, if both sides are mobile and the breath hold also makes them more mobile. No, if they're moving, they're moving. And if they're moving, you don't even need to do a breath hold to test. If they're moving, it's dealer's choice and you can go wherever you want. And we'll talk about that a little bit more too in the lecture. So we'll go ahead and get started because like all the other day, we've got a lot to cover. So I'll share my screen, and as questions come up, still drop them in the chat for sure. Okay. So call 2, we're talking about, we're going to review a little bit on assessment guidelines, how to do the test, interpretation of the test. And we're going to talk about treatment guidelines and options, the treatment options that I shared in the Teachable platform. But remember, treatment, I want you to yes, experience the new treatments, but also I want you to see how your own tools that you've been using work for you, right? Because that's the name of the game. The fact that the tools you have now are perfectly capable of getting great results, especially when we are using them in the spot where the body wants or is directing you. So yes, don't just only use my treatments. So anywhere the body directs you, you can use any treatment. It can be general massage, can be exercise, can be self-massage, can be dry needling, cupping, whatever your tool is, use that in that area. Then the big part of today is talking a lot about SI joint pain, and then also how to make this test and this lens of view work even better. We're going to talk about the LTAP Level 1 course, and then share some cases. This is the other big question that always comes up, and I did see it came up in the comments of Teachable too, was how to explain to your client what you're doing and why you're, if they come in with wrist pain, why you're starting at the SI joint. And basically, I do always explain it to my athletes. I explain it in the same exact way I explain it to you all, except I try not to use fancy anatomy words. Though sometimes, given the right person, you can still use those terms too. But basically, this is what I say. I'm like, hey, we're going to start, we'll give you two explanations. If they've already told me what's going on, or like if this is a patient I've already worked with and they're used to me doing things a certain way, then I will be honest with them. I'll be like, hey, I'm taking a new course. I'm going to try some different things on you today, and I want you to be curious with me. So this course basically is demonstrating that the anatomy of the SI joint connects to everything. And oftentimes when the joint is not moving well, it's because not that there's a problem with the joint, but because there's a protection pattern at something more important. And so the body sort of splints it, almost like a cast would immobilize the joint to protect it. That's, our body can do that with the muscles and connective tissue. And so I'm going to start my evaluation with the SI joint, and then based on the feedback I get, I might start treatment on you in a different spot. But don't worry, I'll still get to your wrist, or I'll still get to, fill in the blank of whatever they're coming to see you for. You want to assure them that even though you're doing something that is maybe out of the norm for you or different than they've had in past experiences, that you do still care about what they're coming in for, and you will still make time for it. And usually they're cool. Most of my athletes, they are like, I don't really care what you do, as long as when I get off this table, I feel better. So knock yourself out. And then the other thing too, is it opens up the door for conversation and curiosity, which is not only like what I'm asking you all to do when you're doing this, is to be curious about what the body has to say. And it's an opportunity for the client to see that too. And this is an important opportunity because it starts to give the power back to the client and seeing the bigger picture of everything in their body is connected, and how a simple thing like, taking time to do a different breath exercise or do like some, facial massage can make an impact on things so far away in their body. So it just creates some curiosity. So I point out what I'm feeling with them as I get comfortable, right? When you're first practicing just how it feels, you can even tell them that I'm practicing a new test. I want to get as many reps in as many bodies as possible. Is it okay if I use yours? Most of the time they love that. Once you feel comfortable with it, you can just say like, hey, let's see if it's moving. And you can tell them, oh, see how the right side doesn't really move. And when I press down, it rotates the whole pelvis. But on the left side, I press down and it gives a little bit. And then they're like, oh yeah, I didn't notice, but now that you pointed out, I did. And then you're like, okay, well, take an inhale breath and hold it. And then I'm going to do the test again. And you do the test again and be like, oh, look at that. Now on that side, I press down and it moves a little bit just like the other side do. Isn't that interesting that the breath would change so much? And then that gets the wheels turning in the client's head, and they're like, oh my gosh, why would a breath change that so much? And so then this is your opportunity to teach them about how powerful the breath is in terms of a nervous system standpoint, but also in terms of changing the pressure in the different cavities of our body, and how the pressure change influences the sensory information going to and from the organs. So I'd say most of the time, I find that a lot of practitioners don't have this open dialogue with their clients, and that's very, it's never been how I've operated, because my belief is that your the athlete, whoever you're working with, they will be more invested and more of an active participant in their care the more they understand what's going on and the more they understand what you're doing. And so we're motivating them through education. So education is a big part of what I do, not just to other professionals, but to my client themselves. In fact, a lot of my clients who've been working with me for years and decades, some of them, I would trust them helping a fellow teammate out over some of the practitioners out there too, because they've learned so much from me along the way. In fact, the athlete I'm currently seeing on my trip here, that is the case. A lot of his teammates sometimes go up to him and be like, hey, my hamstrings bothering me. What would you do? And he gives them different nerve guides or self-massage exercises that I've taught him. And then they try it and it helps. And they're like, wow, how'd that help? So I treat everyone from a knowledge-based level the same. It doesn't matter to me if you're the athlete, the general population person, physical therapist, athletic trainer, doctor, chiropractor, massage therapist, personal trainer, or strength coach. I speak in the same way so everyone can learn, because I don't think knowledge about the body should be behind like a paywall to people who are only in the profession. I think we would all feel better in our bodies and treat people better if we understood just how everything was connected and influenced by so many different things, including the viscera and the nervous system, emotions, and all those kind of things. All right. So it's like, this is my soapbox of this should be fun anatomy and movement and organ health and all these things. Like, this should be a fundamental thing that everyone learns in school to improve your own body ownership, body agency, body awareness, self-image, right? The more you can appreciate how amazing our body is, the more kindness you usually meet it with and meet other people with. So that's the long explanation of what I do, but I just explain to them what I'm doing, and I'm transparent when I'm trying something new, and I'm transparent of I'm trying to get better, because most people really appreciate it when someone is on their team trying to learn everything that they can to help them out with their problem. So don't be afraid to just be honest and open with your clients. All right, so let me turn my do not disturb on. A review of the test protocol. So results G-code course is basically the first test of the LTAP, the locator test assessment protocol. That first test is the SI joint mobility locator test. During this week and for this test, I've introduced 2 ways to assess it for a couple of reasons. One is to have a sort of built-in checkpoint for you, because ideally they should give you the same information. And then also to help out the providers who either are not licensed to touch or are doing work in a virtual setting. So the first one is the license to touch hands-on version. It's a supine SI joint mobility test. It's more of like a true joint assessment of the end feel. You want to make sure your angle of the force is as close to being on the joint line as possible, which I talked about in the video, like changing the angles of your forearms. This also means bringing your body up over the pelvis. So this is sometimes things that I see, especially in the in-person LTAP course. I correct this on people a lot. And it makes sense, because over the pelvis is also over the private area. And so sometimes people feel uncomfortable being sort of on top of that area. But it is important to to get your center of mass a little bit more over that area so that you're giving a more precise glide of the joint. When your arms are farther out and it's just your arms, you're trying to, it's like you have to muscle it with your hands, and it's not as sensitive because you're having to create so much tension in your hand in order to put enough force in it. When your body's over the top of someone, even though it looks like it's more force, it's actually less force because you have more receptors in your body and more leverage over them to make the movement happen. Okay. So you're basically assessing the quality of the anterior to posterior glide and end feel of the joint without and then with a breath hold. A normal end feel is a firm ligamentous end feel, and it feels like a spring, a really stiff spring though, right? If you can imagine a really stiff spring or a really stiff rubber band and trying to lengthen it, there is a spring to it. It follows your hand back when you let go of the force, but it's not like a trampoline. It's not bouncy, right? So understanding what that firm ligamentous end feel feels like. And for us hands-on practitioners that we feel end feels at joints a lot, that you've felt this firmness of a ligamentous end feel. It should feel very similar. Oftentimes, if it's a hard end feel, what you'll see is instant rotation of the entire pelvis. Now, the shape and size of the pelvis sometimes will dictate how much of a rotation there really will be. So I want you to not rely on that movement, right? I still want you to just try to feel the hardness of the actual joint feel. And a reminder, we're not assessing hypermobility. We're either assessing, does it move or does it not move? Is it mobile or not, right? It is impossible, almost impossible to truly assess if this joint is hypermobile or not, right? So we're just noting, does it move or does it not move? We'll talk about hypermobility in a little bit too when we talk about pain, but truly all we're looking at for these tests is it moving and is it not moving? And importantly, does it change with a breath hold? So you're going to repeat this test with a breath hold as if there was a hypomobile side. And the breath hold is not a huge deep breath. It's just simply inhaling through the nose and holding it. The non-hands-on test, well, in quotes, hands-on, right? Because ideally you're still palpating, especially as you're training your eye into seeing these movements under the body. But it's more okay for a non-hands-on licensed provider because you're not applying a force, you're just monitoring movement, right? So it's just touch. Is the standing march test, also called Gillette's test or Gillet. I'm not sure how to pronounce his last name, but it's a single leg hip flexion test, and we're observing disassociative movement of the innominate bone and the sacrum at the SI joint with and without a breath hold. So normal would be that the innominate bone, the pelvis, moves into a posterior tilt or posterior rotation, and the sacrum maintains a relatively upright position. Hypomobile would be that the innominate bone does not move into posterior rotation with independent of the sacrum. So they go together or just nothing happens at all. Sometimes you'll see a side bending, right? So this test too, you're still doing with a breath hold if there is a hypomobility. So the interpretation, this is what this flow sheet is and this slide is. If there is a hypomobility and the breath hold changes that hypomobility, the breath, when they hold their breath and you test it again and is no longer hypomobile, then that is the traffic cop directing you to the viscera or central nervous system. If there is a hypomobility and they hold their breath and it doesn't change, meaning when they're doing a breath hold and you test it, it's still not moving, then that's directing you to do treatment on the same side of the lower extremity in the periphery or the joint itself. It's totally your call at this point if you want to do that. Now, if both joints, right and left side, are mobile, there's no need to repeat it with the breath hold. Just, it's mobile, so that's great. That means the body is not in a big protective pattern on, a protective pattern to the viscera, the central nervous system, or the peripheral neurovascular structures. And so this is sort of the body granting you permission to do treatment at the area of your choice as the clinician or the client's choice. Right? So this is this concept of the traffic cop, right? So if the joint is hypomobile and it changes with the breath hold, we're going to go over to the left side of the screen, treat the central nervous system and viscera. If the joint is hypomobile and it doesn't change with the breath hold, we're going to go to the right side of the screen and we're going to treat the lower extremity on the side of the test that was hypomobile. If both of them move, both of them are mobile, then we go down to the star, and that's area of your choice. Area of your choice might still be around the diaphragm or in the head or in the same side leg. It's totally up to you. But the chances of getting good results are a lot higher because your body is not in that protective pattern, right? So here are the assessment guidelines for clinicians, for licensed to touch providers, right? So I would do the locator tests first. So when somebody comes in, ideally, if it's a new patient, I actually ask them not to tell me what's going on until I can do this first bit of my assessment. Because the less information I know, the less biased I will be about what I expect to see. So I want the most non-biased opinion I can get, or non-biased like starting place as I can get. So when they come in, I start them immediately with the LTAP, right? In this case, it would be just the first test, the SI joint mobility locator test assessment. So the results sheet code. And I then once I know where to start, right? Once the traffic cop has directed me, then I can talk to them and take a subjective history. After my subjective history, then I'm going to assess the orthopedic tests or the movement assessment, whatever your current evaluation or assessment is that you want to look at regarding what's going on in their body. That this might be provocation tests, it might be joint mobility, strength, motor control, movement patterns, whatever it is. This is your opportunity to evaluate those now. Okay, so that's the assessment guidelines. Then you would treat where the body directed you, or the traffic cop directed you, and then repeat all the assessments, which we'll talk about with the treatment guidelines. So right now, this is the assessment guidelines for the clinician. Now let's talk about the assessment guidelines for the movement practitioner. So the non-licensed to touch practitioner, or obviously if you're doing virtual sessions, this would be it. Same thing, ideally, they come in without a conversation about what hurts or what their goals are. And then we start with the LTAP, the first test of the LTAP, the results sheet code. And then once the traffic cop has directed me where to go, I know where I'm going to start. Then I'll talk to them about what's going on. What are they coming in for today? Then I will assess any baseline movements. Again, this is, whatever movements you like to look at. Squat, rotation, forward fold. If you're not used to assessing something, I recommend you start assessing something, because this is going to help you and the client buy into this lens of view, but also like get to see how cool the body is, right? And why the sequence to where you start does matter. So in my example of a movement practitioner standpoint, sometimes I'll use this in a group setting standpoint. So if I'm doing a group setting, I used to, during track season, I every week on their day off, I would teach a regen session, which is like a intelligent movement, almost sort of like yoga type style or Pilates mat class type style class. And in order to make sure that I'm getting the most out of their time with me, before I started the class, I evaluated everybody with the SI joint locator test. And I was able to then categorize them into groups. I had a group of people that were going to start in the viscera or the central nervous system. I had a group of people that were going to start on the lower extremity, either right side or left side. So I told them to remember what side. And then I had a group of people that I was like, you get to pick where you want to start. You can jump in with the group that's going to start here, or the jump in the group that's going to start here. And then once I had them separated, I was like, okay, the first exercise for the visceral and nervous system group is going to be like the gorgeous ball neck anew. And the first exercise for everybody in the lower extremity on the side I told you to do, it's going to be common perineal nerve glide or a calf massage, right? And then once we did that first treatment, then we came back together as a full group and continued on, right? So massage therapists. So this is also a question I get a lot of the times from my massage therapists in the classes, because they don't always assess movement, especially if somebody's coming in for a massage. Sometimes that can be weird to be like, well, before you lay down, I want to look at some movements, right? I still want you doing one assessment, right? Because I want you to doing at least this locator test assessment. You're going to do it first. Then you can talk about what they want out of their massage for the day. And then instead of, you can either try a movement if that's something that you like to do and you're used to. It can be a passive joint range of motion test if you want to, though if it's passive, I recommend you pointing out to the client what quality and range of motion it is. Or you can use the top trigger points, right? You can look at the top trigger points and see how activated they are, and that can be what you're retesting too. So maybe that looks like hip abduction or shoulder flexion. Maybe it's a trigger point at the TFL or the forearm extensors, the masseter of the jaw or the peroneals, wherever you want, but you're just seeing, right? We need something to assess so we can know if our intervention was helpful. So then the treatment guidelines, in a perfect world, I like to try to do 3 rounds of this LTAP or results sheet code. At minimum, at least once, it's going to be good, right? So again, the assessment is you start with the test, see where the body directs you. You do the rest of your orthopedic things. You treat where the body directs you, and then you reassess, including this test again. You reassess the SI joint, you reassess the orthopedic tests, because we want to see, one, did it change the orthopedic stuff we care about? And 2, we're asking the body again, is there anything else you're protecting? Because you have to think about it as like layers of an onion. Every time we ask the body, we kind of go back to the SI joint. We're asking the body, are you still protecting something important, or can I finally treat where I want? So you might have a scenario where you test the SI joint, the right side, let's say the right side is hypomobile. It changes with the breath hold. So you know it's viscera, central nervous system. You do your ortho test. You end up with like 10 things. Then you treat the viscera, central nervous system. Let's say you do like the trigeminal nerve glide. Then you reassess the orthopedic things. And maybe your list from 10 things is now 5 things. And then you reassess the SI joint again. And now it's the left side that's not moving. And you do a breath hold and it moves. Okay, so then it's still visceral and central nervous system. Since I just did something at the central nervous system, I'll pick viscera now. So maybe I'm going to do the sideline breathing with a gorgeous ball around the liver. So I do a round of that and I reassess the orthopedics. And now those 5 things are 2 things. And then I reassess the SI joint. And now, oh, right side moves, left side moves. Great. Or maybe it's right side stuck again. Okay, breath hold. Do the breath hold. No, right side still stuck. Okay, now I'm right lower leg or right leg. And I can pick anywhere in the right leg. Right? So that's what I mean by we're always going back, because we always have to go back to the traffic cop and be like, am I good to go where I want, or is there still traffic? All right. Let me see a couple questions because I know it was on interpretation. Let me scroll back. So one question from Laura was, does it mean anything if both sides are mobile and the breath hold also makes them more mobile? It doesn't mean anything. If they're mobile, you don't even need to do a breath hold. So it just means you can do wherever you want. I did have some people in the comments of Teachable saying that they're getting a lot of people with mobile SI joints with both sides. That's not typically what I see. It can be. It could just mean that your population is really healthy. So depending on what type of professional you are, if you're working with a lot of healthy people, then you're going to see more of that. If you're working with people with a lot of aches and pains and injuries, probably not going to see that. If you are working with people with a lot of aches and pains and injuries and they're both coming up mobile, I'd say recheck the tips for a successful assessment, because I wonder if you're seeing things wrong or feeling things wrong. Also, it could just be the week of people you're seeing are really mobile, so hard to tell. When I teach this inside the LTAP Level 1 course, during the online course, I have people send me videos of their assessments so I can give you feedback on your hand placement and feedback on what's happening. And then, of course, that's the value of doing an in-person course, is I can actually have you do it on me, or I can watch you do it on somebody and give you real-time feedback too. So just a little bit on that. I can't. All right. Dawn said, I had bilateral hip hypomobility with someone, breath changed only one side. What's your interpretation of that? It still directs me to the viscera and central nervous system. So, yeah. And then she said, also with someone else, hypomobility didn't change with breath. After treatment, they were still the same, but did change with breath this time. Well, you didn't say where you did treatment, so I don't know. So if the hypomobility didn't change with breath, that's directing you to the same side of the hypomobility of the lower extremity. So don't know where you did the treatment, but maybe you picked a leg. Oops. Oh, I can't, my chat box is not cooperating. There we go. And then someone said, what if both hypomobile and don't change with breath hold? Well, if both of them feel the same, they don't move, and both of them are not moving, they feel the same, then that's when having the entire LTAP is nice, because then you can use the LTAP number 5 assessment to help determine this using the pulses. So using the distal posterior tibialis pulse. That is how I would choose between right and left. Worst case scenario, you have a 50-50 chance. So you could treat both right and left lower legs, but still, if there's a hypomobility that's not changing with the breath hold, I would look to a strategic reason why in the legs. Now, this is also an important thing to ask somebody, like and look at their medical history. Do they have any history of fusion of the SI joint or arthritis? Would you suspect arthritis of the joint? Are they having any actual SI joint pain? Have they had any diseases that would lead to issues at the SI joint? Like I think ankylosing spondylitis would be one of them. So making sure you ask questions like thinking about and we'll talk later when we talk about SI joint pain, but we'll talk about hypomobility from a structural thing and hypomobility from a strategic thing, right? So that's what you have to filter out. I talked about on the first call in regards to how the SI joint is considered a visceral joint and considered like a very strategic joint, meaning most of the time, like I'd say 80% of the time, if not even more, a lot of, at least in the age group that I see, if there is a hypomobility, is strategic and it's not a structural reason. Now, and as we age, of course, we know some joints can have a little bit more lack of mobility from perhaps bone spurs and just degenerative changes. So that would be the incidence of structural changes like arthritis. So something to think about. But at the end of the day, too, like I said, the LTAP number 5 test can help us figure out where to start on which leg as well. Kendall asked, what is both hypomobile? Meaning the right side of the joint and the left side of the joint both give you the result of a hard end feel, which probably would rotate the pelvis. And then you asked, can you explain strategic hypomobility? What is an example of that? Yes, that's what I was just talking about. So a strategic hypomobility is the visceral or the central nervous system or peripheral nervous system sending like not clear messages to the body of these protective patterns. And so the body neurologically tightens things up around the joint to limit mobility. So that's what, when the breath hold changes things, that's what we're seeing is the strategic hypomobility. All right. The rest of the questions I'll get to a little later. Those were the ones about interpretation. Okay. So if you get to 3 rounds of this assessment and you still haven't treated the area or eliminated the problems around the area the patient came in, please make sure that you touch that area, you do treatment in the area. You don't want to not completely, work on what's there, right? So I always tell people I want to blend what the patient comes in and asks me for with what I think they need. They need to leave with having felt both of those come together. So treatment guidelines, treatment options. The cool thing about the viscera and the central nervous system is they're also will relate to each other. So there's some carryover if you pick very cranial based central nervous system exercises or even sacral based central nervous system exercises. They're going to have an effect on the viscera, right? We know that because we know that one, everything's connected, but in general, the viscera, the sensory information from the viscera is carried along the vagus nerve and obturator nerve, pelvic sphincter nerves, right? So there is a relationship already there. So we talked about on the first call, this concept of like narrowing our assessment. Same thing with treatment. So assessment and treatment, the more narrow and precise we can get, the better treatment response we're going to have, right? So it's going to be more of the pebble getting thrown in the water and having this long lasting ripple effect when we can get really specific. So the first test of the result or of the LTAP, the results cheat code, the traffic cop directing us that it's central nervous system and viscera, right? So if somebody comes in with left knee pain and the SI joint is hypomobile and it changes with a breath hold, the traffic cop says, okay, there is a protective pattern being driven by the central nervous system and the viscera. That has already gotten me from here to here. And I'm going to have better outcome by starting like with some sort of thing going at the diaphragm or even like the thorax instead of just going to the leg, the knee, the ankle, or the hip. right? But if the next layer would be to determine, is it central nervous system or is it visceral? That would get us here, right? That makes our pebble smaller and smaller. But this is the cool thing, is a lot of these treatments are going to have overlap. And this is all about, again, why the tool is less important than being in the right spot. So we can keep it pretty general and still have pretty amazing results. So the treatment options that are based around visceral and central nervous system treatments typically are like breathing, self-massage, neurology exercises. So if you have any, like a Z Health background or any sort of like vestibular training, that can be considered central nervous system. Any neural resets. Spine mobility is a great one that can do central nervous system and viscera, and we're going to see a reason why in a second. I can't emphasize enough, use the tools that you love and you know well. They get you good results already, more than likely. Now they're going to get you even better results when you know when and where to use them. As far as when the travecopter wrecks you to the lower extremity on the hypomobile side, I want you to think bigger than the SI joint. Remember that the hypomobility is typically a result of a protective pattern, typically a result of information coming from the peripheral neurovascular areas driving this strategic hypomobility. So instead of just going and treating the SI joint itself, what's their ankle mobility like? What's their fibula movement like? What's their knee like? What's their hip mobility? Treat something along those patterns and see how it gets changed in the SI joint. So when we look at treatment options for the viscera specifically, the benefit of visceral mobility exercises are nervous system relaxation. That's so wonderful. Why is this happening? Because when our visceral organs are manipulated or mobilized or influenced, that sensory information is given to the vagus nerve, which is one of our parasympathetic nerves. Also has a sympathetic response too, but in general, when we're doing these things, when we're giving more sensory information to the system, it is very relaxing to the nervous system. That is also, like, think of digestion, right? What happens with digestion with our visceral organs, our digestive organs, they start moving and grooving as food is in there, and the digestive system starts happening, and it sends a message to the brain like, oh shoot, we need to digest. And so it facilitates even more of that parasympathetic response. And like I said before, when treating areas of the viscera that are innervated by the phrenic nerve and the vagus nerve, you could consider that also treating the central nervous system. Benefit of the neural resets, which are like the cranial nerve stimulating exercises, is also nervous system relaxation and decreased tension on the cranial meninges. This is really what I'm trying to go for with those, is changing the intracranial pressure. And then the benefit of spinal mobility. Spinal mobility treats both the central nervous system via the spinal dura and reflexively treats the viscera by the viscerosomatic reflexes. This is a table of viscerosomatic reflexes. So if you're new to this concept, each visceral organ has a spinal segment reflex that it goes with. This is basically the sympathetic innervation to the organs from these levels nerve roots, right? So you can use this relationship to have an effect on these organs, right? So you can do very specific spine articulation in these segments. You can do manual therapy around these segments, whatever, again, remember, whatever tool you want. I actually think if you were to ask me to be like, Anna, what do you think is a better exercise modality? I would, between yoga and Pilates, what would you choose? I choose Pilates because of this fact 100% why. Pilates, the thing they do right is segmental spine mobility. And segmental spine mobility is very, very good for viscera and the central nervous system. Yoga tends to not have as much spinal articulation in it. That's why I would pick it. Now, of course, it depends on the yoga teacher and the yoga type, but in general, Pilates is the modality that articulates the spine a lot. And this can show you exactly why that's so wonderful. So the treatment options for the viscera that I provided in the course for you are some simple ones. I gave you 4 visceral ones, 4 neural ones, and I think 2 or 3 lower extremity ones. So the visceral mobility exercises I gave you were sideline visceral massage with the Courgeous ball, liver-focused embodiment during thoracolumbar rotation. I gave you one that's called restoring the upper thoracic flexion for the mediastinum, so organs of the mediastinum. And then I gave you an obturator nerve glide. I put the obturator nerve glide in with the visceral exercises because of the relationship of the obturator nerve to the parietal peritoneum, which we talked about in call 1. Now, the obturator nerve glide, though, too, could be used for the lower extremity because the obturator nerve also innervates the hip joint, the knee joint, and the adductors. The neural resets I provided is the basic exercise by Stanley Rosenberg. This is always a very popular exercise. Stanley Rosenberg is the author of the book Accessing the Power of the Vagus Nerve. That's what that is from. I gave you simple scalp massage. I gave you a cannonball stretch, which is a specific area of the abdomen that is you can do with the Courgeous ball or just with your hands. And then I provided a trigeminal nerve glide, which is one of my favorites because the trigeminal nerve, which if you continue on to the LTAP Level 1 course, we talk about the trigeminal nerve a lot when we talk about central nervous system tension test because it influences the meninges and intracranial pressure so much. The lower extremity treatment options for the hypomobile side, I provided the obturator nerve glide, like we talked about, the common perineal nerve glide, and then lateral ankle tilts. Again, some really simple things that tend to be big dial movers on treatment-wise. But remember, I'm sure you have a ton of treatments for the extremities. Again, you might have a ton of treatments for the spine, a ton of treatments for the thorax. You can use anything you want. It does not have to be these. I just wanted to share some of my quick, easy ones that are maybe different than tools you already have. Or maybe they're the same. It just sort of depends. So let's talk about I'm going to look at the questions again because there were some questions about some of the treatments, and then we're going to go over some treatment scenarios. Okay, let me scroll back. Dawn asked for visceral treatments on the ball. What are we okay and not okay with feeling? How should it feel? Well, it's going to feel different for everyone, but in general, I would say that it should not be painful. It should not be painful. And there's a difference between a little uncomfortable and painful, and that's very subjective to the person. So again, I just have a conversation with them and be like, this shouldn't feel uncomfortable. You got to watch their body language too. Sometimes people are still in this like no pain, no gain type of mindset. And so they'll be like, yeah, it's fine. And then you'll be like looking at their body language and be like, are you sure? And they're like, yeah, it's fine. If they keep saying it's fine and you see on their body it's not fine, stop the exercise and change it to be gentler or pick a different exercise. It shouldn't feel super visceral. And I know that's a weird way to describe it, but a visceral feeling sometimes makes you feel a little nauseous, maybe a little like anxious. I don't want it to feel like that. It should be comfortable. So if lying on the floor directly on the ball is uncomfortable, try sideline. If sideline's still uncomfortable, take it to the wall, take gravity out of it. If it's still too much with the ball, deflate the ball so it's less pressure, right? There's a lot of things that you can change in order to make the experience different. And it might be that you don't start with the ball and you just start with some directed breathing into different areas, right? Or some just like skin stretching, skin massage, or like the type of skin stretch I showed with the cannon bomb exercise. You can do that anywhere in the body. You don't have to, it doesn't have to be only in that spot. And then the other question was, how is this sent home for homework or not? Yes, I often give people these for homework. I don't rely on my patients to buy the props I needed. So if I'm going to give them a prop, like if I'm going to ask them to do something with the Corgis ball, I give it to them. So I buy them wholesale, and I think they're a really great tool, and so much so that I want all my people using them. And so I take the hurdle, the obstacle out of the equation for them, and I just give it to them. It's just incorporated in my cost of my treatment session with them. Totally your call if you do that or not. Just know that if they don't already have the prop, then they're probably not going to do the exercise for you, because even though we can easily order things on Amazon, people just never get around to it sometimes. So I tend to give stuff that I know has very low barrier for entry for homework. All right. Looking at the questions. Kelly asked me, do you often get regressions, mobile to hypomobile, on the second or third test? Yeah, well, and it's not a regression. It's just like after you do an intervention, things change, and we're unpeeling the layers of the onion. So yeah, you might see right side go from hypomobile to mobile, but then the left side go from mobile to hypomobile, or you might see no change, or you might see both of them move, or any scenario of that. There is not a sequence that is typical, or it is just whatever the body is offering you. Okay. Another question, what's one of your favorite Pilates exercises for segmental spine mobility? A standing roll down. That's my favorite. It's easily accessible. You don't need any equipment. You can modify it, modify the segments, even quadruped, cat, cow, segmentally. That's easy. Those are easy. Another question, do you also use the tune-up balls for areas not in the abdomen? Yep. I use my top massage balls. The balls that I have for my athletes are the Corgis ball. All sizes of the tune-up balls, so the alpha balls, the therapy balls, and the therapy plus balls. And then I also give them a pair of 4-inch soft Franklin smooth balls. Those are my favorite. And if I don't think I have them linked in the course, but if you need to know where to get all of those and want to use my affiliate links, you can go to my Instagram profile link, which I'll just drop it in the chat for you. And I have everything linked there. Another great spot to get the Franklin balls is the OPTP. But Amazon and Tune Up Fitness is usually where I buy stuff. All right, that looks like all the questions so far as far as the treatments. And so we'll continue on. All right, so treatment scenario. We've got right knee pain. You do the locator test. Oh, this is funny. Oh yeah, I was like, what is this? Do the locator test, see where it directs you, take a subjective history if it's appropriate. After the locator test, so it's not biased by the outcome, assess movement baseline or top trigger points. I like to look at hip abduction, shoulder flexion, TFL, forearm, peroneals. Then here's like a scenario that you might see. Oh, I gotta move my chat box. I can't see my notes. Okay. So it was hypomobile on the right, and it improved with breath hold. So that directs me to the central nervous system and the viscera. The objective dysfunctions, right? The orthopedic test showed limited right ankle dorsiflexion, limited right prone knee bend, pain with a rear leg lunge, and left hip flexion was limited. I did treatment. The treatment I chose was sideline visceral massage with the Corgus ball. Then I retested. Now the SI joint mobility locator test, it changed. Now it's hypomobile on the left, and it did not change with the breath hold. So that is directing me to the lower extremity on the left. The orthopedic tests also changed. Now they have improved right ankle dorsiflexion. The right prone knee bend is still limited, and I did not test the lunge. The treatment I chose was the common left-sided common perineal nerve glide, retested. SI joint mobility locator test, right side moved, left side moved, great. Retest the orthopedics. The right-sided prone knee bend improved, left hip flexion improved. I retested the lunge, and there was no pain, which is a huge win. So from here, we could continue to look at their right knee. Like we could do soft tissue to the right knee and knee joint mob, you know, depending on what was going on. Or we could be like, how cool is that? And then let's just go do some strengthening exercises or whatever else you had planned for their day. But either way, you have a very happy person that no longer has right knee pain with their lunge. So here's an example with foot pain. Right foot pain, SI joint mobility locator set assessment showed hypomobile on the left. It improved with the breath hold. So that's directing me to viscera and central nervous system. They had limited right ankle dorsiflexion, limited right hip adduction, and limited left hip flexion. Chose the same sort of treatment, sideline visceral self-massage. Retest. The SI joint mobility locator test was now hypomobile on the left, and it improved with breath hold again, right? So I had the same thing, still telling me that there is a visceral and central nervous system protection pattern. Their orthopedics showed some improvement, right? So that visceral massage was not necessarily the wrong thing. It made some changes for us. It improved left hip flexion. But right ankle dorsiflexion and hip adduction is still limited. So now this time I tried a little bit more like central nervous system driven tests. So I did the basic exercise and a right-sided accessory nerve glide. Then I retested. The SI joint mobility locator test was now hypomobile on the right, and it did not change with breath hold. So that directed me to the right side of the lower extremity. Retested the orthopedics, improved right hip adduction, but right ankle dorsiflexion was limited. Well, it's great because I have permission to do treatment on the right side. So I went straight to that right ankle and worked on dorsiflexion. Such a great pattern. It led me right to where the problem was. An example with left sciatica. So the SI joint mobility locator test assessment was hypomobile on the right. It improved with the breath hold. So that directed me to the central nervous system and the viscera. Left hip flexion limited, left hip external rotation limited, right limited prone knee bend. Treatment was to the liver with visceral massage with a Corgus ball and then the rotational embodiment exercise. Retested, SI joint mobility locator test showed me that both sides were moving. Great. Clinician's choice. I retested my orthopedics to see where I wanted to go now. Improved left hip flexion, improved external rotation, no more limit in prone knee bend, and the sciatica was gone. So I was like, wonderful. This is awesome. So the rest of the treatment was movement exercises to decrease fear, right? Because sometimes the patient can't believe that their sciatica is gone. So a lot of the work you're going to do is like reintroducing movements that maybe were painful and sensitized in the first place to show them and give them the confidence that they're going to be good. And then teaching some breathing and thoracic rotation, because I had such a great response with the liver massage, and the liver and the diaphragm and breathing are all very related to each other. And that could become their take-home exercises. So shoulder pain, an example here, maybe the SI joint mobility locator assessment test is hypomobile on the right and it improves with breath hold. So this is pointing towards central nervous system and viscera. Orthopedic test showed right limited hip flexion, limited left hip prone knee bend, left shoulder flexion is limited and painful, and they also have decreased left glenohumeral joint internal rotation. Treatment I chose was prone thoracic curve restoration for breathing. So it was really treating a lot of the mediastinal structures in the diaphragm. Retested. The SI joint was now hypomobile on the right and did not change with breath hold. So now I'm being directed to the right lower leg, or the right lower extremity. The orthopedics was improved left hip prone knee bend, improved left shoulder flexion, and decreased pain. However, there was still decreased left glenohumeral internal rotation and flexion. So treatment was directed at the right posterior deep hip rotators, self-massage, and then I retested. SI joint mobility locator tests, right side moved, left side moved. Great, treatment of my choice. Redid the orthopedics, glenohumeral internal rotation was improved, and right hip flexion was improved. So now I can work on exercises around the shoulder to strengthen things. I can work on thoracic mobility, thoracic exercises, anything really I can do now because the body has granted me permission. All right, so those were some examples. We talked about this already, though I think there was another question on it as well. All right. Oh, no, we're good. One of the questions was, what percentage of the time do you find the LTAP direct into the CNS viscera? Is this test only used with pain diagnoses? No, this test is used for everything. Anytime somebody comes in, this is helping me to figure out where to start. Doesn't matter if they have pain or not, or where their pain is, or where their pain is not. I'm using this test always. And what percentage is it central nervous system or viscera? Often, but also not. I mean, it just kind of depends. It depends on the person. It depends on the situation. There's not necessarily a percentage. This is what makes it kind of exciting, is that you never know what you're going to get. But like I said before, like 80% of the time, it's going to be either it changes with the breath hold or it doesn't. And in terms of like being a strategic thing, it's not going to be a structural at the actual SI joint itself most of the time. I'd say 20% is on the high end, that it's actually the joint itself. Another question, if testing the trigger points, are you testing sensitivity of them before and after? Yes, if I'm testing trigger points, I'm using it as an orthopedic assessment. So I'm testing how many fingers away from the trigger point they're tender, they're activated. All right, we'll continue on because we got some very cognitive stuff when we're talking about SI joint pain. Now, like I just answered the question before, this test I'm doing regardless of what they come in with. They come in with wrist pain, I start with the SI joint mobility locator test. They come in with knee pain, I start with the SI joint mobility locator test. They come with neck pain, I start with the SI joint mobility locator test. They come in with SI joint pain, I start with the SI joint mobility locator test. So when it comes to SI joint pain, part of the reason that it's probably a challenge in the world that we live in is because of this relationship of strategic hypomobility of the SI joint from influences from the viscera in the central nervous system and the peripheral nervous system, right? We have learned from this week that so often a hypomobility of the SI joint is coming from somewhere else. Most of the time, just like in the spine, right? Like in the spine, you might be familiar that if somebody has a spinal fusion, then the areas, the level of spine problems that they will have next is always going to be on either side of the fusion. Because when we have a hypomobility somewhere, when we have a joint not moving, the joint adjacent to it starts moving too much, right? It starts doing all the work because it can't move through here. So what I typically see with people with SI joint pain is the painful side is not the problem. The painful side is this side that's moving too much. And getting the hypomobile side to move is the goal, which we're going to talk about in a second. However, if you're trying to diagnose that their pain is from that SI joint that's moving too much, which there's always a big emphasis on being able to assess and diagnose exactly what the pain generator is, which is not a bad thing. It can be very helpful, but it's not always that helpful in terms of what you're going to do in that session. It might be helpful in terms of like, you might want to go back and see your doctor for an injection or not, or have an explanation for your patient of why the doctor is not being successful with their interventions, right? And that's when these SI joint pain provocation tests come in. So if you look at the research, and this is sort of going back to, we talked about in the first call of the March test is not a reliable test. Well, I hate to break it to you, there's not a reliable test for SI joint pain and dysfunction. Sometimes those words are interchanged in the literature, pain and dysfunction. Most of the time, dysfunction is supposed to mean a hypomobile joint. But I've noticed in the literature, it's often interchanged with pain. So number one, that makes things even more confusing and less helpful for us. But we're going to say, regardless of the tests that are out there for the SI joint, the mechanical tests, many of them are listed here. So the March test that we know, not necessarily the supine test that we use. And remember too, the tests like the March test, traditionally in the research for SI joint dysfunction, the breath hold has nothing to do with it. The breath hold is the piece that we're adding in for the visceral and central nervous system piece. This is the new part of it. So just the March test on its own is not shown to be reliable. And we already talked about last week what I think about that. But also, all of these tests are not reliable. The thigh thrust, the Galen's test, Faber's test, the distraction test, the compression test, the sacral thrust, all of them don't have that great of numbers around reliability, validity, specificity, all those things that we would care about from a research standpoint, which is why the researchers have proposed clusters of tests to diagnose true SI joint pain. So these clusters of tests, there's 3 of them: the cluster of van der Werf, the cluster of Laslet, and then Levin described a cluster too, though they didn't name it. These clusters are designed to help make clinical decision making easier than relying on one test. So typically, depending on what cluster you're looking at, if you have 2 to 4 or like 3 or more of the tests that provoke pain, it is indicative of perhaps the pain being generated from the SI joint itself. But there is no single test that is proof for it. Interesting enough, if all of these tests are negative, meaning none of them provoke pain, it is a very strong indication that the SI joint is not the problem. So that's good to know. The other interesting thing is no single test and none of these clusters correlated with post-injection relief. Injecting the SI joint with a lidocaine or like cortisone is the gold standard for diagnosis, which is not ideal because that's a very invasive way to get a diagnosis, right? But it makes sense because a lot of people have a hard time helping people with SI joint pain. And so when the person's at the doctor, they're like, nothing's helped, they are willing to try anything. They're okay with an invasive thing like an injection half the time. The cool thing is you're going to be able to help a ton of these people before they ever get to that spot, because we're seeing the SI joint with a completely different lens of view, which makes sense why none of these tests are reliable. Okay, so I'm not going to go over each one of these tests because this is not about diagnosing SI joint pain, but know that you know, if people truly have SI joint pain and you're trying to diagnose it or help the doctor diagnose it in order to maybe get them that pain relieving injection, this is what you're going to want to do. And I've been there, and I've helped an athlete through that, and it was very helpful because no one else really considered it. And it was the problem. But what I did treatment for him to make the injection even more successful is all the stuff I'm teaching you, and what we're going to talk about in a second with the hypomobile joint versus the hypermobile joint. If you want to learn more about the cluster of tests and like truly practicing those, you can go, one of, I think the best resources is from Physiopedia. They have a whole list of all of these and videos and the descriptions of the research, if that's something that you're interested in. For what it's worth as well, the sacral thrust test, that is Stu McGill's go-to test when he is looking at people with low back pain and SI joint pain. He uses the sacral thrust on his own to diagnose or lean towards SI joint versus low back, at least according to when I was in one of his workshops. All right, so now it's helpful to understand the SI joint pain patterns. And when you look at the pain patterns and the referrals, what's cool is it should make sense to you based on what we learn in call 1 about what nerves innervate the joint. And then it's like way more clear what's going on and why the peripheral nervous system has such an influence on this joint. So pain patterns follow the nerves that innervate the joint or provide sensation to the area. This is great because it can give info on what's being irritated, but it's, of course, it's not conclusive. Both the joint and the area have a lot of information, innervation, which is why pain is so common, right? There's 5 nerves that innervate the joint, and then there is 3 sets of cutaneous nerves that innervate the skin around that area. And so it's no wonder that you can have all these common referred pain spots. You can have, let me use my cursor to point to these too. So you can have the pain here more in the like iliohypogastric area of the abdomen. This one gets, people think that they're having like appendix problems, ovary problems. This is a fairly common referral spot for SI joint pain because of the iliohypogastric nerve relationship to the obturator nerve. They come both from the lumbar plexus. Same thing here too, along the just above the pubic bone at the medial or proximal end. Well, I guess we call it the medial end of the inguinal ligament, right where the obturator nerve comes out of the obturator canal there. Very common spot as well as you can get, it can even be genitofemoral nerve irritation from this relationship of the obturator nerve and lumbar plexus. Then traditionally, right on the front of the thigh and the hip, the femoral nerve. Makes sense. Down the leg, we've got this whole like lateral side of the leg and foot. That is the, like a common perineal nerve distribution. And again, the lumbosacral trunk is one of the nerves that innervates the SI joint. So that makes sense. On the back side, you have this spot right above the joint. I'd say that's often more classically when people think they have SI joint pain, they're saying this bothers them. This is really commonly cluneal nerve involvement, especially also right around the rim of the ilium is often cluneal nerve, and then right around the border of the sacrum itself, it's the sacral cluneal nerves. And then you get this posterior lateral hip, that's tibial nerve, which again, lumbosacral trunk and nerve to the quadratus femoris, and the superior gluteal nerve. So the cool thing is if you never really thought about what nerves innervated the SI joint before our first call on Sunday, we already have a good indication of it from the pain referral patterns, right? For what it's worth as well, I had forgotten on call 1 to list out the nerve to the quadratus femoris as the 5th nerve that innervates the joint as well. So my observations in my almost 21 years of practice has been that hypermobility is most associated with driving the pain. Pain is often on the side that is moving versus the hypomobile side. In fact, I'm naming it hypermobile for the fact that it's moving and it's painful, and so probably moving too much. But remember at the beginning, I said it's like almost virtually impossible to feel too much movement and know that it's too much, right? It's just not, we can't measure it very well. But often it's rarely like a true hypermobility, meaning like a true big laxity. It's sometimes just moving a little bit more and irritating the nerves that are innervating it, or just like getting a lot of information, and those nerves are causing those referral patterns. Almost always someone who has SI joint pain has one side that's hypomobile. It is less common to see pain on the hypomobile side, though it does happen. I've recently had it happen with a friend of mine who came to see me for treatment because nobody could help him. And that is exactly what was going on, was he was getting very obturator nerve type referrals and the iliohypogastric type of referral pain. And then down the leg, he was kind of getting all of them. And he was hypomobile, didn't change with the breath hold. And when I would treat his leg, nothing would really change it. So he was just hypomobile all the time. And sure enough, he got imaging, and more than likely he had, well, not more than likely, he did have bone spurs and arthritis, irritating the obturator nerve, which in the literature that's called the obturator nerve entrapment. And it's a fairly common generator of pain on the hypomobile SI joint. So that's a very good indication of that. And then a lot of times, I'd say the majority of the time when someone has pain, it's actually just from the cutaneous nerves having a little bit of cutaneous nerve entrapment along the thoracolumbar fascia, from the cluneal nerves. And so it's not from the SI joint itself. It can be from the lumbar spine. I see that quite a bit. Lumbar spine facet joint restrictions causing some referred pain down the lumbar plexus to the SI joint. And yeah, so that's sort of what I see in my clinical practice, is that hypermobility is it's the pain that's moving, that is the side that moving is causing the pain. If I can get the hypomobile side to move and distribute movement between the two joints, then they don't have pain anymore. So that's the goal. Remember, we are not using the SI joint mobility locator test to diagnose SI joint pain. We're not using it to really even diagnose structural hypomobility versus strategic or functional hypomobility. We're using it simply to determine if there's influence from the viscera, the central nervous system, or the peripheral nervous systems. We can make the assumption based on that information that it might be a strategic hypomobility, right? In the absence of visceral or central nervous system issues, a hypomobile test, it directs us to the lower extremity, which may or may not be the joint itself, right? And like I've said already multiple times, in my experience in the population I work with, it's usually always driven from somewhere else, not the joint itself. Doesn't mean I never treat the SI joint ligaments, but not as often as I treat other things that influence the mobility of that joint. And a reminder, we're not assessing or diagnosing a hypermobility or pain generator. So if you were to see it sort of on a little bit more of a diagram, if we have pain with hypomobility, not necessarily, this doesn't mean necessarily pain on the side of hypermobility. This is just, you have SI joint pain, you're complaining of SI joint pain, and you have a hypomobile SI joint. It's a strategic hypomobility if mobility change with the breath hold, then it's visceral and central nervous system protection pattern. If the hypomobility did not change with the breath hold, then it's coming from the lower extremity peripheral neurovascular areas. Those are the examples of that strategic hypomobility. And we talked about it already, but again, this is just a diagram. What about structural hypomobility? Things like SI joint arthritis, like my friend had, SI joint fusion after surgery. You're probably there's a possibility, not a possibility. I don't know why I use the word possibility. It should just said you're going to get a false test. It's not going to be a helpful test for us anymore. When the assessment test is in an environment that it can't give us information, it's not a useful test anymore. So we got to go somewhere else, which is when I would proceed with the rest of the LTAP and rely on my other tests to guide me to where the body might be protecting, right? So, and we talked about that a little bit before when someone asked the question, if both sides were hypomobile and they didn't change with the breath hold, what would you do? I would use some other tests. I would use the pulse. I would use the inhibition tests. I would use the rest of the LTAP. Okay. So here is what happens with pain with mobility or hypermobility. And we talked about it. Bilateral, if both sides are moving, right? If both sides of the SI joint are moving, and you want to determine if it truly is a SI joint pain generator versus maybe like the lumbar spine or the hip joint, right? Because the hip labrum can kind of refer to some similar patterns too. Then you can try an injection. You know, if you're working with a doc, you can try the cluster of pain provocation tests. You can try bracing or stability training to increase stiffness across the joint and see if that possibly help. In this case, though, too, you could still proceed with the rest of the LTAP to see if maybe you're missing something and not getting a good test because of this hypermobility, you know, because maybe maybe they're an EDS patient and they truly do have hypermobile SI joints, or maybe they're newly postpartum and so they do still have a ton of ligament laxity, and so Again, it's kind of like the scenario with SI joint fusion. It is not a good test anymore because it's not going to give us good information. So then we would rely on other tests. Okay. If there is a unilateral mobility, we're back to the last slide, basically. Did the hypomobility change with a breath hold or not? Okay. And I saw a couple questions, so I'm going to make sure I get those. Don asks, I'm not sure you covered this, but is there a reason we assess from the AP palpation and not prone PA? I don't have a reason other than I've never done it in prone. So I'm not sure if you, I've never done it in prone. I did try a prone test called the Shimpy test 2 years ago, I think now, that I read in the literature that could be helpful, and it just did not get me the same information. And so for this, I didn't feel like it was a valid test. And the research actually was published in a questionable journal article, or journal. It was published in a questionable journal. And so I don't think it was even like probably very good research. Whenever research articles are not in like the gold standard research journals, sort of makes you start thinking that maybe there's something wrong with the statistics or the methods of the test. And so that was the issue. It was not a PA glide, though. It was a movement test, more like the march test, but in extension. But yeah, I don't do the prone. I'm not comfortable with that. But if you are and you want to try it and you get similar information, like, go for it. But for me and what I know works for the LTAP, the supine test seems to give me the best information. Okay, so with that said, I am sure, because I've been seeing comments roll in and getting messages from people on Instagram and email. You're getting good results. You're seeing some crazy changes, which is great. But how do we get even better results? So remember, like I said, the more we can narrow in, the more specific and precise we get with both our assessments and our treatment, the better and more long-lasting results we can get. So not just knowing that it's viscera or central nervous system or what side of the lower extremity needs treatment, but knowing exactly where we can go is helpful, right? Knowing exactly that it's the liver or the lung or the cranium or the neck or the bladder, right? If we can get really focused in, or like even in the lower extremity, it's the popliteal fossa, or it's the proximal tib fib joint, or it's the, posterior deep hip rotators. The more we can get more specific with where the body is directing us, the better results we're going to get. That's what the rest of the LTAP can help us with. So, a reminder, the LTAP stands for the Locator Test Assessment Protocol. It's 5 orthopedic-based tests. So this was number 1. And it's going to get us that more narrowed focus. We're trying to get our focus narrow like a pebble, so when we throw it in the water, we have a bigger ripple effect. So just to give you a visual of that, remember the results cheat code was just pulled out of the LTAP. It's basically the first week of the LTAP Level 1 course, the online course. It's the first test. So this whole week is giving you a taster of what it is like in that course. So in call 1, we talked about it, but the 5 tests are looking at this one, the SI joint mobility. Second one is the central nervous system tension pattern test. Then we go to the thorax and we do a decompression and inhibition test. Then we use visceral inhibitions in the abdomen and the pelvis with manual muscle tests or pulses. And then in the lower extremity, we do neurovascular entrapment inhibition tests with the pulse as well. And the whole LTAP is asking the 3 questions. Are you protecting something important? That's the question that we've been asking this whole week with the results cheat code. And then the next 2 questions, we get further into it with the LTAP, which is what is it exactly? Where is it exactly? And then this is the important part. What is the sequence of treatment? And this is important because oftentimes, this is how I view it, is the results cheat code and the LTAP. It's like an investigator, right? We're trying to narrow in our focus on what needs to get done. But remember, the treatment guidelines were multiple rounds of this, which it sounds like it takes a long time. It's not. This is a very quick assessment. Multiple rounds, though, to keep knocking down our orthopedic list, because I'm trying to find the proper sequence. It's like a combination lock, right? I can give you the treatments, right? I can tell you I did cupping to the lateral quad and nerve glide for the obturator nerve, and treatment around the liver, and maybe a joint mob at their neck, right? I can tell you those 4 things I did, and you could try them, but without knowing the sequence, you're not going to get the same results. It's not going to open the lock, right? So it's not just enough to know where to go, but the sequence of which it is informed to us by the body. That's what the rest of the LTAP does. And that's what going through the LTAP in repeated rounds does for us, is it starts to give us this combination to undo the lock, right? To get the best results. So this is the flow chart in like full LTAP mode. So in the LTAP, learn that whole course teaches you all those tests and this whole entire flow sheet to figure out this combination of where to do treatments to get the best outcome. And by best outcomes, I mean treatments that stick and last over time and quickly can help guarantee results for people. So there's this is like, this is now I'm inviting you to the LTAP level 1 course. There's 2 options, 3 options really. There is an online course. It's 6 weeks. We've already talked about the core beliefs. SI joint connects everything. Where you start matters. That's what we've been doing this week. And now the rest of the course, we learn that the sequence you treat matters, right? The combination lock and specificity and precision matters. In the online course, it starts October 9th, so a week from Monday. There is a live call every week. And each week is focused on one test, and then we put it all together. And then there's also, we talk a little bit about what to do for the upper extremity from a treatment standpoint with this new lens of view. There's pre-recorded tutorials of assessments, anatomy, and treatments, very similar to this week. It includes more treatment options. So if you're wanting more treatment options around all this stuff, it is there. You get Voxer access to me, basically 24/7 for the whole 6 weeks. So you can ask me anything, send me videos, pictures, get my feedback, get help with cases. You get lifetime access to this course. And the doors close a week from Friday, right? So the cost is $597, and there is a payment plan as well. And then for participating in the results cheat code, you all get $150 off the course as well, and we'll talk about that in a second. Then there's an in-person course. So the in-person course, there's one coming up in San Diego in November 18th and 19th, which is the Saturday and Sunday right before Thanksgiving. Spots are limited. There's only 17 spots left in this course. It's at Olympus Movement and Performance, a great performance training facility up in Carlsbad or Vista, California, just about 40 minutes north of San Diego. It's from 9 a.m. to 6 p.m. on Saturday and 9 a.m. to 4 p.m. on Sunday. The educational content is the same as the online course. The difference is obviously there's not weekly calls because you get 2 days with me in person. So you get the in-person experience, real-time treatment ideas and examples. We'll probably also go over a quick spine assessment to get additional information on the central nervous system, tension, information, and treatment. You get to connect with other like-minded clinicians, get feedback on your hands-on skills. Everyone has done the in-person course, has loved it and thought it was so helpful. And you too get the access to this course as a bonus. There's an early bird discount of $100 off until the 11th, I believe, of October. But then also for results cheat code, you get $150 off, and there's payment plans available. Then there is the bundle. So in a perfect world, I would love for you to do both the 6-week online course and the in-person course. This gives you the best teaching and learning experience because it has a nice slow pace of the weekly content in the online course that you get to practice and come with all the questions to the 2-day course. The thing I love about the 2-day course is it's all hands-on. It's literally 12 or 13 hours of hands-on treatment and assessment. So it's not like you're sitting in a course and having me lecture at you. You've already done the lecture by the time you get there. So the other benefit of the bundle is it's the greatest value. So you get $300 off by bundling it, and it's an extra $50 off for you participating in the results cheat code. So it's $350 off. And then it also means that you're eligible to sit for the LTAP certification that I'm rolling out in 2024. So in order to be certified, you'll have to do the 6-week course, the in-person course, and then take the test and submit case studies. And then you also have exclusive professional development opportunities and discounts on the mentorship course and calls. So that's the bundle. Here's the info of the money off for participating in the results cheat code and the coupon code. The sales page, if you want to go today, I'll drop it in the chat as well. The coupon expires Tuesday at midnight Pacific time. Let me do this. Oh. Oh, my mouse went away. There we go. So you have some days to finish this course. Think about it. If you know you're in and want to join now, you're welcome to. But I'll be sending more emails about it in the upcoming days. The other thing I'll drop in the chat for you is the check-in for this call. So in the call today for the raffle prizes, and the code word today is pumpkin. The free access for this course ends a week from Friday. So if you're behind, no worries, you'll have time to finish before all the content goes away. If you enroll in any version of the LTAP Level 1, you'll have free access to it. And I'll announce all the raffle prize winners on Monday. And the more results you share, the more entries into the end of the course raffle. So at the end of, I think on day 6 in the Teachable, I ask for you to share case studies. So the more of those that you share, the more entries into the raffle that you will get. And then a reminder that the code for the discount for the LTAP ends on Tuesday. I know I already shared some treatment cases a little bit earlier ago, but also in the online Teachable platform, I have these 3 cases recorded for you too. So if you want to hear more about actual cases, there's some examples for you in the Teachable. And also today's podcast gives a good example of a recent case as well. So that's it for the formal lecture. Want to go through and make sure I don't miss any other questions. And then if you have more questions, please drop them in the chat, or you can ask to unmute. I can unmute you if you want to ask them. I think there was a question I didn't get to. Let's see. Oh, Becky asked, have I seen any cases of correlation between SI joint pain and barrel-shaped ribs? I have a client who presents with SI joint pain, but also has pain in ribs when lying on her stomach. Her doctor from childhood told her that she has the ribs of an opera singer. And since you brought up breathing, I wanted to ask. Not necessarily correlation, but it would be interesting to see. So it'll be interesting when you do this test on her to see how it changes and where the where you pick for treatment and how that influences her mobility as well as her pain in both locations for sure. It is reasonable that it could influence it for sure. The other questions that were not necessarily in the chat, but some that were in the course module that I wanted to talk about. So some questions on pregnancy. So we talked about the other day, pregnancy being a contraindication of doing the test if they are not allowed to lay on their back. But if they're allowed to lay on your back, you can do it. The other question was in terms of pregnancy or like post motor vehicle accident or high velocity injury with laxity. So we talked about that a little bit with just pain with hypermobility or hypermobility in general. If that would be a scenario where you don't think you're going to get great information from the test. So yeah, it's not necessarily contraindication. It's just I wouldn't do it because I don't feel like it would give me as valuable of information. And so then I would lean on the rest of the LTAP tests. In terms of acute injury to the SI joint itself, or just acute injury in general, whenever the body is going through something like that, it is sort of in a protection mode on purpose. And so, you don't necessarily always want to break that. So use your best judgment with that too. So it's like if they're post motor vehicle accident and they have some SI joint pain, I might just skip it and leave it alone for, 12 days, 14 days, 21 days minimum, to just give the body some time to do its healing thing and like tighten things up and like, get wound approximation and things like that. So, it doesn't have to be a contraindication, but just a precaution that you keep in mind, right? Use your best clinical judgment as you would with anything like that. Another question was using visceral mobility while pregnant. So in general, if someone is pregnant, you don't want to do very precise and specific visceral mobility. So what we're trained in the Barral Institute is you don't do mobility, like manipulation, mobilizations when people are pregnant. It can be distracting to the brain on what the purpose of the focus of the body is. The focus of the body and the brain while someone is pregnant should be the health of the baby. And so you don't want to be distracting that information. Also, it's a general rule. You don't want to be the last person to touch a pregnant person if they have a complication with the baby. So it's a liability. I can't tell you what kind of liability you're comfortable taking on, but in general, my rule is I don't do a whole lot of specific manual therapy with my pregnant clients. Also, I don't have a lot of pregnant clients. The majority of people I work with are male athletes. So if I'm working on someone pregnant, it's a friend, a family member, or a friend or family member of my athletes. So again, use your best clinical judgment. The thing is too, I'm not teaching you specific and precise visceral manipulation. Everything I give you is pretty gentle. So as long as the pregnant person is cleared for exercise and movement, then I'm like, you're cleared for that kind of stuff. Another person was talking about how they were doing multiple tests. Remember, the supine test especially is a joint mob. So 2 to 3 max. 2 to 3 max. If you're not getting the information that you need to with 2 to 3 repetitions, then you're just move on to the next patient, move on to the next test, because the more you mobilize it, the worse of a test it's going to give, right? It becomes not a valid test anymore. Another question that's come up a couple times too in doing the tests in the supine position is what to do if somebody has hip flexor tightness, right? And just like I would for scoliosis, I'm going to bolster them and meet their body where they're at. So if you need to bring the legs up and a little bit of hip flexion to make sure you're able to mobilize, do the test in the joint plane better, then please do that. So that might look like putting them in a hook lying position, or it might look like just putting bolsters under their knees. Use your best judgment. I've done it with bent knees and it works great. I still get great information with bent knees. The hip position shouldn't really matter. Oh, somebody asked too, like, what should I do if I, somebody was like, did I not do it right if I tried an intervention and it didn't change? And it's like, no, there's no right or wrong here. We're just being curious of what changed. And as I gave you the cases that we talked about, right? Sometimes it's like the right side was hypomobile, it changed with the breath hold, you did something, the orthopedics improved, but the SI joint was still hypomobile and it didn't change. That's just, we unpeeled a layer of the onion and we have new information. And so we try another intervention, right? So no problem with that. I think that was the list. That's my list. That was the list of all the questions. I think there was a new one in the chat. Let me look. Ian said, one of my athletes has pain that is off and on in the TFL area and or the QL area of the low back, both on the right side. Some days she is fine and other days are more painful. Do you think this would indicate more of a visceral or central nervous issue or possibly an SI joint issue? She did show hypomobile on the supine test, but mobile on the Sandy March test. If you're getting, so first of all, if you're getting two different informations on the supine test and the March test, that means something's not right in terms of your hand placement or who knows, but they should match up, especially if you're doing them one after another. So whichever test you feel most comfortable with, I would trust that one. And it means that the other test, you need to see if your alignment, your positioning, that kind of thing is. Okay. So, and then the rest of your question is, it could be either. It could be central nervous system or it could be visceral. Hard to really know. Or it could be SI joint pain. But chances are, once you get more comfortable and have those two tests line up with the same result, you'll probably have a more clear picture of what's going on. So, yeah. Anybody else have anything? Any more questions? Nope. All right. Well, thank you for being here. We got, let's see, today was day 4. So we got Thursday. Gosh, tomorrow's Thursday already. This week has gone by fast. So we have 2 more days. Thursday, keep practicing, add in the interventions if you haven't already today. Play around with the new ones or use your old ones. Like I say, the tool doesn't matter, but work on doing the test on as many people, still getting the reps, and then trying an intervention and then retesting. If you haven't been retesting the SI joint, make sure you do that. If you haven't been retesting your orthopedics, definitely make sure that you're doing that, right? Because this is going to show you how powerful this is. Kim asked, do you have to do the LTAP before the mentorship? How much is mentorship and what is it? The mentorship I only offer once a year. I'm not even sure I'm going to offer it next year, to be honest. The mentorship is $4,000 and it's 17 weeks and it includes the information from the LTAP. You do not have to do the LTAP level 1 first in order to be in the mentorship. You can do them consecutively or separately or just one and not the other, totally up to you. If I do the mentorship next year, I usually offer it starting, it's usually in like August through September. Not August, sorry, April through September. It's 17 weeks. Yeah. Yeah, you're welcome. Thank you all for being here. You'll be hearing, just because this is our final live call, you'll still be hearing from me every day. I'll send you an email when the recording's ready. I'll send you an email tomorrow with the tasks for the day and Friday with the tasks for Friday. And then some follow-up emails Saturday, Sunday, Monday, Tuesday, reminding you of the course and the discount ending. And if you have any questions, I'll still be answering questions in the comments and in my emails until the free access ends on October 6th. So you're welcome. Thank you so much. It's fun. I love sharing this information. Love giving you a new lens of view and a different perspective of some old tests and solving some reasons for why SI joint pain can be such a bugger. And hopefully it is going to be way easier for you all now. So thank you for joining, and we'll see you in the emails. Have a good night or day, depending where you are in the world.